Welcome to Deep Dive Dialogue, where we explore advancing sepsis management with precision medicine. Today, we have with us Dr. Girish Gaur with over 15 years of experience in lab operations, quality assurance, patient support, and molecular diagnostics. Dr. Gaur brings comprehensive expertise across both infectious and non infectious domains. He holds a degree in life sciences with a master's in genetics, specializing in applied molecular genetics. His research oriented qualification underscore his commitment to academic excellence. Dr. Gaur has held key leadership positions in various departments, showcasing his strong leadership capabilities and strategic vision. He has demonstrated exceptional skill in managing diverse products, including onco, neuropsychiatry, diagnostic, prognostic, and theranostic, highlighting his versatility. Dr. Gaur has collaborated with renowned researchers globally, making significant contribution to projects related to acute promyelocytic leukemia and investigating genetic factors in disease pathogenesis. So, welcome, Dr. Gaur.
Thank you, Agnishta. That was so nice of you to have such a comprehensive introduction. Thank you so much.
So, to begin with the rise in antimicrobial resistance, how can personalized antibiotic treatment address this issue in sepsis management?
Okay, so let's start with sepsis first. And sepsis, because it is a very topic which is very near to us as an organization also. I'm working at Rivaara Labs right now, and we are developing a lot of tools for specifically Indian pathogens. Because if you see overall, WHO and ICMR has worked comprehensively and brought up a document which tells us India-specific pathogens. Now, the problem has been over the past. The problem has been that we have been utilizing kits which have been coming from outside India, and so at Rivaara we are trying to cut down the cost of these kits and maybe make these tools available for masses in India. Coming back to your question, where we were discussing about antimicrobial resistance, personalized antibiotic treatment, and how can we address all these issues in sepsis management. So what I'll do is I'll try to break this question into two parts. One would be the inherent challenges of sepsis management, and second would be let us understand personalized antibiotic treatment in this era of antimicrobial resistance, because we have a lot of pathogens which are showing a lot of antibiotic resistance, and these are somehow involved in sepsis also. So coming back to sepsis in itself is a life-threatening condition that happens to the body. That happens when the body's immune system becomes aggressively against itself, and underlying infection is the cause.
Yeah.
So the trigger, no doubt, is the cause. Primarily, it is the bacterial infection, and in bacterial infection also, gram-negative bacteria are the predominant ones. But with that, having said that, we also see pathogenesis through fungal, viral, and parasitic pathogens also. So again, coming back to sepsis, is body's reaction which causes damage to its own tissue and organs, and may lead to shock with multiple organ failures, sometimes fatality, if it is not treated at early stage. If you see the data, it says that every hour delay in treatment actually increases or should I say decreases the overall survival rate by 8%. So we have to remember that sepsis has to be treated very fast. The intervention has to be very fast. So what we need here, we need early diagnosis. By early diagnosis, what we can do is we can identify the pathogen which is responsible for this disease. We also need to understand that there are some high-risk groups like newborn babies, older adults, people who already have some issues with their immune system. They need extra attention. So one is the identification of the pathogen, which is very important. Now let's come to the second part of the question, where we need to understand the importance of, should I say, personalized antibiotic treatment, or should I say personalized medicine in the era of microbial resistance. So should I say antimicrobial resistance? And how to address this in context of sepsis. Personalized medicine, if we talk about personalized medicine, it has been being practiced in oncology space since a lot of time now, almost like 20 to 25 years now. But in case of infectious disease, this has come late. What Yes, it has come. It has a lot of potential. If we just take an example of mycobacterium tuberculosis, if we go back 20 years and see the scenario of TB detection and diagnosis 20 years back, it was primarily ZN staining, it was primarily culture. Molecular techniques were available only, should I say, conventional PCR was available to diagnose. But with advent of multiple technologies like real-time PCRs, this whole scenario has changed. Now what we can do is we can identify pathogen in a paucibacillary sample also on the first day of the sample being given to the lab. And with that, we can also give information about first-line drug, second-line drug, and maybe on day 2, when all these results are available, the clinician takes a informed decision about how to go about treatment. If the patient is already, say, resistant to rifampicin or INH, they can go for second line. And if there is some resistance coming up in second line also, they can always modify the treatment as and when required. Now let's come back to the sepsis domain, because we have talked about microbiota. The whole personalized antibiotic treatment, I think this is going to be a game changer, because we will be able to target the therapy properly. Second is the misuse. Why I say misuse is because we don't have information on day 1 about what is the pathogen, because normally what happens is culture takes these are conventional technologies, I don't deny they are right now the gold standards, but they take some time. So it takes more than 24 to 48 hours to give some kind of information about the pathogen. But in case of real-time PCRs, or should I say molecular techniques coming like NGS, they have the potential of giving results within 6 to 12 hours or 18 hours. And that will help us to target the therapy, because we are able to identify the pathogen first, and secondly, even the AMR genes can be identified at the same time. Reducing, or should I say, maybe even eliminating the misuse, because what happens in sepsis, we go for a broad spectrum antibiotic use in the first go itself. But if we are able to get some answers within, say, 12 hours, we can tailor make some, at least we can pull back some antibiotics, and we can reduce the load of antibiotics for that specific pathogen. Again, if we can target the therapy, if we can reduce the misuse, so ultimately what will happen? There would be an improved outcome for the patient. So that is what the target should be. But having said that, there are a lot of challenges also that we need to overcome right now, because ultimately we are looking at a total strategy change, where the current gold standard is being challenged, should I not say challenged, but is being supplemented with the newer technologies. Rapid diagnostics, no doubt, is coming up in a big way. But again, molecular technologies have an inherent challenge of cost. So cost and availability is a challenge, because if we want to improve the overall scenario of sepsis, we need to actually bring down the cost significantly so that it becomes available for masses. Secondly, having a molecular lab at all locations inside the country it's a challenge, obviously, because a lot of infrastructure requirements is there, and that are the challenges. Again, third would be, because no doubt we are putting pressure on R&Ds to create newer technologies, but again, bacteria is not sitting still. They are also acquiring a lot of resistance. So what happens? We also need to have a continuous improvement of the existing technologies, so as to keep a pace with the resistances that are being acquired by the bacteria. So overall, what I feel is personalized antibiotic treatment for sepsis, it holds immense potential, but there are some challenges which we need to mitigate, and I think down the line it will be a powerful tool to combat antimicrobial resistance and improve the overall patient.
Right. Partly you have addressed my multi-omic approach to sepsis. So my next question was that how multi-omic techniques and NGS, of course, help in identifying the sepsis and help clinicians determine the most effective diagnostic therapeutic approaches for everyone. So partly you have answered that. You can elaborate.
So I just wanted to be a bit in detail on the omics technologies, basically.
Okay.
Let us first understand the omics, multi-omics. Multi-omics actually is the different layers of our central dogma of life. This hits multiple layers of our central dogma of life. So if you start with genomics actually is like probing the whole genes, DNA of the pathogen or maybe the human. Then comes the transcriptomics. It probes the whole RNA or RNA mechanisms of the whole cells or pathogens. Then comes proteomics. Proteomics is probing the protein level changes. Then comes metabolomics, which is like there are a lot of molecules which help in metabolism. And so how is the person metabolizing different things, and what are the molecules that get affected? Changes in that is being like, it is the science which comes under the metabolomics.
Right.
Then we have microbiologicals, or should I say microbiomics. Normally what happens is our gut has a lot of bacteria, our skin has a lot of bacteria. There are useful bacteria also and pathogenic bacteria also. And to study these in details, we normally just hit one bacteria or two bacteria when we are diagnosing the disease. But these all changes in the bacterial population actually brings out a lot of changes in our health scenario also. So to study all these changes comes under the microbiomics.
Yeah.
So as far as when we actually study all these layers of central dogma of life, we get a better understanding of how things are going on in the system. And I think again, for infectious disease, this has come late. For oncology, this has been like going on since at least 2 decades now. We have been trying to understand how the genomic changes, transcribe into RNA changes, and translate into protein changes.
Right.
And are there any mechanisms where the whole microbiomics and the metabolomics play some role in the final outcomes? So what we are trying to do is we are trying to get a complete picture of the whole scenario.
Right.
Okay. If you see, there are a lot of tests which are available right now when we talk about multi-gene expression assays like MAPRINT, Blueprint, where they're actually studying 70 genes, 90 genes, expression levels at a single go. What they want to do is they don't want to miss out on the, upstream pathways and downstream pathways. So they want to give a comprehensive picture of that cancer, and maybe if the treating clinician gets a proper information about the tumor, they will be able to give proper treatment and the outcomes would be much better.
Right.
So similarly, coming back to multi-omics scenario in sepsis, I think even sepsis management, we are trying, and it will be helpful in the whole overall management of sepsis. What will happen is once multi-omics strategies are applied in sepsis, we will be able to get better insights into, because sepsis is not just a single disease, it is a complex situation where we have heterogeneity also. But we need to understand that heterogeneity. Our patients maybe of younger age, they behave differently in sepsis. Maybe adults behave differently in sepsis, and the third category is older patients. Maybe they behave differently. Then there is a category which is immunocompromised.
Yeah.
Maybe they behave differently, because everything is your younger age population, middle age population, adult population with the immunocompromised population. They will have different types of uh, things going on inside the body. So how do they defend themselves? How is the mechanism behaving in these patients? We'll get a comprehensive idea of what is happening. So what will happen now once we start subtyping these patients? There will be improved diagnostics. Maybe we will just not look at the pathogen only. We'll also look at different biomarkers, because ultimately all these biomarkers are spread across the central dogma, from DNA to RNA to protein and to metabolites. Even microbial, so we are already doing it. But again, these biomarkers can give us some information about how the disease is progressing. So that would actually change, and maybe based on that, the treatment modalities will change. Treatment, we will understand when we are treating, the way we are treating, what is the response in these categories, these subtypes that we have defined. And moreover, I think with that, we'll also get an understanding of the resistance patterns. How are they developing? Are they developing because we are giving some drugs, or are they developing because there is some interplay between host mechanisms and the pathogen mechanisms? So again, there are examples, historical examples, where we see that host mechanisms also put a pressure on the pathogen to go in a different way and develop resistance. So maybe we get a lot of understanding about what is happening and how it is happening, and then it will actually help us to define the treatments properly. And again, coming back to our final, I think, point where we want to reach is better outcomes. So overall, I think if we see multi-omics approach, it is going to bring a paradigm shift in sepsis, and maybe we will be able to predict treatment responses properly. We'll be able to have better diagnostic accuracies, because we will not be depending just on targeting the pathogens. We may also have multiple biomarkers which will help us to maybe come to a conclusion that yes, these are sepsis. Because there are a lot of cases right now when we don't even get to ID the pathogens. Almost 80%, 85% cases, we don't even ID the pathogens. And we know based on clinical parameters that patient is in sepsis. So maybe these biomarkers will help us to predict everything, and maybe the prognosis of the patient will be good, and we'll be able to save lives.
Definitely, definitely. So what are your views on clinical use of artificial intelligence or machine learning based softwares that identify patients at risk of having or developing sepsis?
Okay, I think this is a very interesting topic of late: artificial intelligence, machine learning. I think clinically, slowly and steadily, we will be moving towards artificial intelligence and machine learning. I think in every domain of healthcare, we will be moving towards it. A lot of advantages are there. AI never sleeps. Machine learning never stops. So if you feed a lot of data, I think machine will start churning the data in and try and make sense out of it. Artificial intelligence will try and do something and then put it in front of the stakeholders that this is what I feel. I think one would be the data that we can put. But yes, the data would be huge. Again, the advantage first, let's talk about the advantage. I think it will be able to give us a lot of improved accuracy. Maybe over the time, it will be able to reduce the workloads on stakeholders. And maybe, because this is still, I know there are different tools which are being pursued for regulatory approvals in AI sector also, in sepsis also. There are a lot of things going on. But still, I think standardization would also be improved for patient care across the domain. Having said that, so these are all the advantages which we potentially see, but there are a lot of challenges also which we will be coming across. One is we have been talking about data. So AI and machine learning requires a lot of data. What if we are not able to provide proper data during the initial phases itself? There would be a total data bias, which will result in maybe a lot of biases for certain patient populations, and that is to be monitored crucially. Second is, at least in the initial stages, we cannot rely on the AI thing maybe totally, because ultimately clinician thing is clinician thing only.
Yeah.
So that judgment and expertise is very important. It can be a adjunct to what we are doing, but it cannot be totally relied on. So that is what we need to understand. Then there would be a problem of integration also, because what we are thinking is putting a lot of data in the algorithm. Where is the data going to come from? These are going to come from either LIMS, or like hospital information system, HISs. So how are we going to integrate these data? Because ultimately, if we don't give proper data, there is some bias in these systems. Ultimately, it is a simple process, like garbage in, garbage out. If we are not able to give proper data, it will throw garbage to us. Then again, regulatory concerns are always there, because ultimately, final thing is it has to pass through some rigorous process, and regulatory approvals need to be put, so that the confidence of clinicians comes. Otherwise, it is difficult to put this thing in. So overall, what I feel is AI and machine learning would be no doubt a game changer. But there are a lot of things we need to consider before we can actually put it in clinical use.
Right. So my concluding question is, what innovative approaches or strategies do you believe can be implemented to improve the quality of sepsis management in resource-poor settings where access to advanced diagnostic tools and intensive care resources may be limited?
I think India is at a very strategic position, where we have situations where we see resource limitation, and we have situations where we have ample resources to tackle the disease. Go to the interiors of India, you will have resource limited situation. Go to the cities like Delhi, Mumbai, Bangalore, Hyderabad, you have ample resource situations where we have people from out of India also coming to India to get their health care. So I think we are at a very crucial juncture to understand, and maybe this information can be passed on to other stakeholders also. First thing which I feel is surveillance systems can be improved. Early recognition systems can be put in place. Like we have SOFA scores, Q SOFA scores, which are already available. So maybe people can be trained in these resource limited scenarios to how to implement these softwares, how to implement these score systems, and maybe then they can have a proper understanding of how to recognize early signs in these kind of diseases. Then what we can do is we can also look at improving the antibiotic stewardship. Maybe what we can do is we can plan some kind of training, some kind of educational sessions for these resource limited settings, where they can actually make their own antimicrobial stewardship program, where at least the common pathogens which are prevalent there can be treated properly. At least they will understand which antibiotics to give in which scenarios. Again, I think this needs to be done through capacity building and supportive care exercises. But with that, I think there are some initiatives which we can take on the technology front also. I don't know much, but mobile health tools are still there. There are low-cost diagnostic tools which can be used there. Now there are lab on chips, there are lab in a cassette, lab in a briefcase. All these, I know I'm talking a bit louder here, but I think if we try and take these to the interiors, excuse me, interiors of India, I think we will be able to improve some things. I am working on some POCT tools which may become life changing for interiors of India. So I think the key focus is to actually simplify the overall process. We need to have adaptable approaches because one size fits all cannot be applied here also.
Right.
We'll have to understand what is the kind of resource constraint that specific area is facing. And again, coming back to that, collaboration is very important. National level collaboration, international level collaboration, I think within the local healthcare providers, with public healthcare officials, and everybody needs to, I think that information passing, live information passing is important. Maybe that will improve the overall scenarios in the tertiary care, primary care settings in the interiors of it. I think this will actually lead to a better patient outcome, and maybe we are able to reduce a lot of mortality in the interiors or resource constrained scenarios settings.
Right. So with this, we conclude the session. Thank you, Dr. Gaur, for giving us so insightful, information. Thank you so much for joining. Thank you.
Thank you for allowing me to be a part of this journey.
Thank you.